Hi, today we're going to talk about diagnosing CRPS, also known as complex regional pain syndrome. I'm going to have some guests that are going to talk to you about their diagnosis, as well as me telling you my diagnosis story. But first, let's get into some of the technical part about diagnosing. The Association for the Study of Pain made criteria that are used in diagnosing CRPS. The first one is the presence of an initiating bad event, an injury, an IV stick, a surgery, or immobilization. And keep the immobilization in mind when you listen to other people's stories. Continuing pain, allodynia, or hyperplasia that is inappropriate for the level of the injury. Evidence of edema, swelling. Skin changes, such as more hair, less hair, shiny skin, bluish purple tinge to the color. Blood flow, color of the limb, the temperature of the limb. There should be 1.1 degree centigrade indifference between the affected and unaffected limb. A continuous pain, which is caused by a stimulus that normally would not elicit pain. That's what allodynia is. There's static mechanical allodynia, pain in response to touch. For example, your primary injury is your foot. You have pain in response to someone touching lightly your foot. Dynamic mechanical allodynia. This is pain in response to a light touch. For example, the ceiling fan is on and that blowing air causes you pain. Your bed sheets or your clothing can cause you pain. Excessive sweating. Neuromuscular abnormalities, which include a decreased range of motion, dystonia, which we did on what is CRPS, where parts of the limb don't lie as they would normally, weakness or tremors. So when you're diagnosing CRPS, the best tool is a good physician who knows CRPS doing a good history and physical. The visible symptoms can come and go. Tests that are not helpful are imaging X-rays, MRIs, three-phase bone scan, skin biopsies, sympathetic nerve blocks. That what they do is give you the block, and if it helps you, you have RSD. Well, that dates back to when we thought that reflex sympathetic dystrophy only affected the sympathetic nervous system. A sweat test, a nerve test, such as an EMG, or blood tests. None of them can definitively be used for RSD or CRPS diagnosis. This is a thermography image, left versus right. It shows the temperature changes and it shows where the affected part is. This is a reliable method along with a good history and physical. So I was given the triple phase bone scan. It's been used since the 1970s in diagnosing CRPS. A radio-labeled chemical is injected into a vein. The chemical concentrates in the bones. The body is then scanned to check for concentration of the dye in the bone. The problem is it cannot differentiate CRPS from a traumatic injury. For example, I crushed my right foot. Triple phase bone scan was used to diagnose my CRPS in 1998. However, even if I did not have CRPS, the traumatic injury to my foot would have shown the chemical pooling in my foot anyway. So, my diagnosis. On March 4th, 1996, I was driving home from opening a home care case in Philadelphia when a 19-year-old making a left turn turned into the front of my car. I immediately knew something was broken, even though I'd never broken a bone before. I was taken by ambulance to the hospital, a hospital they formerly worked in, and I was seen by the orthopedic resident. Did x-rays, determined there were fractures, put on a splint, gave me a shot of Demerol and some crutches, and sent me on my way with instructions to find my own orthopedic surgeon. The orthopedic surgeon ordered a CT of my right foot, and that's when they determined I had 8 commuted or crushed fractures of the right foot. This was my injury. I was put into a non-weight bearing cast for 8 weeks. Immobilization is a common cause of CRPS. The pain continued. I described symptoms to my orthopedist that are common with CRPS. And unbeknownst to me at that time, he wrote in my chart that the list of the symptoms followed by, but I don't think she has RSD. So after a year, I'm still having pain, swelling, burning. So he decided that I must have traumatic arthritis. So he did a surgery to fuse my right foot. 5 screws were used to fuse my foot together, which this is adding insult to the injury. I was told by after the surgery by all different doctors that the pain was in my head. It was not a physiological problem, it was a psychological problem. Well, I became suicidal. I was hospitalized back in that same hospital on their psych unit. The psychiatrist who was assigned to me told me that my pain was real, and he recommended a chronic pain rehab program at a nearby rehab hospital and go as an outpatient. So, one of the first things I did was to meet with a physiatrist. A physiatrist is someone who specializes in rehab medicine. This program involved physical therapy, occupational therapy, biofeedback, water therapy, group therapy, and individual therapy. And although at that time I still did not have a diagnosis, I did get good tools and a good education about dealing with chronic pain. So once the physiatrist brought up RSD, I needed to know more about it because as a nurse, I'd never heard of it. You have to remember that in 1998, there was no Facebook, there was no Google searches. But as I typed in reflex sympathetic dystrophy, I found one name attached to most of the information, and that was Dr. Robert Schwartzman. At that time, Dr. Schwartzman was not taking new CRPS patients, so I saw his associate, Dr. LaBelle. After confirming the CRPS diagnosis, she recommended a beer block be done. This is a sympathetic nerve block of the foot. A blood pressure cuff is pumped up to cut off the blood flow above the knee. and the medication used in the block was injected into an IV in my foot. Well, after that, my CRPS began to spread. Other sympathetic blocks were done, which caused further spread. At that time, there really weren't many treatments. So they thought if they used a continuous epidural to block the pain signals from my foot to my spinal cord and back, that they may reset themselves. They did not, but I did get 7 days of lowered pain levels. The next thing that was tried was a lidocaine infusion. Again, I was back at Hahnemann Hospital. For 24 hours, no one could start an IV. So the next day they came in, put in a central line, took me to the operating room where I had my first of many ports. The lidocaine worked pretty well the first time, but not the second. Was then suggested that I get a medication pump, also known as an intrathecal pump. Medication is actually delivered in with the spinal fluid. In my case, the medications were morphine and clonidine. But for others, it can be baclofen, which is a muscle relaxer, which can stop spasms and other movement disorders. Well, the problem was that in order to maintain the same level of pain management, we had to keep going up and up and up on the morphine until they couldn't go any higher. In October of 2001, Dr. Schwartzman called, asked me to come in, and he wanted to talk to me about ketamine. He was doing a study with doctors in Germany on ketamine induced coma therapy. We will talk more about that when we get into treatments.